Um, so we're really excited today that we have had the opportunity to invite a colleague from the United Kingdom. And to inform you, I'm talking about Adrian McConnell, who is our next speaker. The English have been advanced in the English language. They're also advanced in the CO world because they actually have a national group investigating and addressing carbon monoxide. So we have learned a great deal from Adrian and with his group's work over the years, and we want to share that with you today. Adrian, are you unmuted?
I think so. I'm not sure that I'd describe us in the UK in 2021 as advanced anymore, but there we are.
Well, you're advanced in the study of COVID too.
Well, maybe, yeah. We're
Turn it over to you.
Yeah, I don't even think about that. Right, I'm going to try and share my screen. I've recently been given a new laptop, so I have a more recent version of Microsoft Office, and I'm just getting the hang of it, so bear with me, please. It's like getting a new car, isn't it? It's, you're scared you're going to touch the brakes and go through the windshield. Right, here we go. Okay. Thank you anyway for inviting me to speak today. Having a look around the virtual room, there's a number of you that I've been lucky enough to meet in person, and I'll just move this thing out of the way, otherwise I'm not going to be able to read my notes. It's just really nice to be here, and it's good to see that so many people are engaged and involved in this. So I am Adrian McConnell. I'm head of charity at the CO Research Trust. I've run the charity for around about 10 years now, and in that time we've moved from a organisation that funds a number of different initiatives from education and awareness to focusing mostly on research. So what I'm going to do is I'm going to give you a little bit of background to the charity, tell you a little bit about our new strategy. In the UK, one of the things we're doing to lobby policymakers is we're looking at something called the housing trilemma. So I thought I'd mention that. Also for healthcare professionals, you've probably heard this one before and you're probably using it in the US. We use the COMA acronym to help healthcare professionals diagnose CO exposure. So I thought I'd quickly just mention that because that's something that we've been looking at and talking about revising in the UK. And then finally, I'll give you a whistle-stop tour of the things that we are up to as a charity. There are some things that perhaps you might like to get involved in, and perhaps some things that you may want to have a look on our website. I was going to give you the full 9 yards about everything we're up to in a broader context, but we've only got half an hour, so I shan't do that. If anyone wants to get in touch with me afterwards, I'm more than happy to arrange the time to have a call and I can chew your ear off about everything else we're up to. So this is basically the introduction. So the CO Research Trust was formed in 2005. We're a registered charity in the UK, and our original purpose was to improve gas safety. In 2010, we changed our name to the Gas Safety Trust and had a broad focus on all sorts of issues around domestic gas safety. With time, we've come to focus on the CO, on carbon monoxide exposure. I've been lobbying my board for a number of years to change our name to something that's more suitable. And finally, in May of this year, we rebranded and renamed ourselves the CO Research Trust. Finally, we have a name that I think says what we do on the tin. So I thought it'd be useful just to set out our new strategy with a new name. They say new year, new you, but this is our what we think is a rather bold strategy for the next 4 or 5 years. So our vision is a world where people are not exposed to carbon monoxide. Not only are people dying, but many are unaware that they're being poisoned at low levels, which can lead to adverse health outcomes. Additionally, there's some evidence that shows that low-level exposure may exacerbate other medical conditions. We've set ourselves 4 ambitious goals. One 0 accidental deaths from CO exposure in 10 years. Secondly, a reliable biomarker for CO exposure and the right treatments and therapeutics. Thirdly, providing better evidence for greater awareness, education and regulation, which will minimise the risk of CO exposure. And then finally, better detection where the risk of CO exposure can't be eliminated. So, where's that? There we go. So these are our key priorities. These will be the areas that we'll be focusing in on in terms of our research over the next 4 to 5 years. Firstly, a novel biomarker. For us, this is a critical area of research. Given the limitations of carboxyhemoglobin, it's essential that a new biomarker is found to make diagnosis easier, to ensure that those who need treatment receive it, and to make sure that all cases of CO exposure are identified so that a true picture emerges. Secondly, better treatment and therapeutics. To improve the treatment and therapeutics for CO exposure, we need to better understand the mechanisms of CO poisoning, to review and build upon current methods, and to further explore the increased susceptibility and specific risks associated with vulnerable groups and those with underlying health conditions. Thirdly, understanding vulnerable groups and comorbidities. It's generally thought that the elderly, children, pregnant women, people living in fuel poverty, and people with underlying health conditions are more susceptible to CO exposure. In order to be able to develop policies and solutions to mitigate these risks, we need to increase our knowledge of why these groups are more vulnerable and what level of risk is. Next, quantifying prevalence and data. This is an important focus for us over the next 5 years. We want to better quantify the prevalence of CO exposure in the UK and elsewhere, capturing both the fatalities and, where possible, CO exposure as a secondary cause, as well as low-level exposure. We'll do this by funding primary data collection, assisting with the aggregation of data collected by others, and supporting the analysis of healthcare datasets held by others, for example, the UK's Biobank. Our next priority is the built environment and energy efficiency measures. I'll cover some more of this when we get a bit further along my presentation. We will continue our interest in the effect that changes to the building regulations, energy efficiency measures, and the way that people heat and cook impact on CO safety. To do this, we're going to work more closely with industry colleagues to establish potential collaborative projects. And finally, last but no means least, other fuels and environments. Whilst the UK's gas industry has taken steps to prevent CO exposure, thanks in part to better regulation and improved technologies, in the UK, other fuel sectors, the picture is less clear. With no requirement to report CO incidents and fewer regulatory requirements, it's unclear what the level of risk and specific issues are, for example, in the solid fuel sector. Similarly, we're going to work towards developing a better understanding of the risks in non-domestic environments. That includes transportation, leisure environments, hospitality and catering, and other specific workplaces. Just briefly, we've set out in our strategy that our approach and the way we work will be innovative, that will be bold and inventive in the pursuit of our vision, seeking new ways to make a difference. We'll be committed. People are at the heart of this charity. We're passionate about preventing death and injury from CO exposure and ensuring that everyone who's been affected has the highest quality of life and chance of recovery. We'll be collaborative. We can only achieve our vision by creating networks and partnerships and a strong CO research community. We collaborate and we value everyone's contribution. And finally, we aim to be intelligent. We aim to be focused and thoughtful in our approach to preventing CO exposure. So next, I just wanted to mention briefly what's become the basis of our lobbying approach over the last 18 months. I thought before I give you an update on our activities elsewhere, I'll talk a little bit about this. Whilst the dangers of outdoor air pollution have been well documented, the often overlooked area of our environment is the indoor space in which we live. It's imperative that we strengthen the understanding of the key risk factors and effects of poor air quality in our homes. In 2016, the Royal College of Paediatrics and Child Health and the Royal College of Physicians estimated that indoor air pollution may have caused or contributed to 99,000 deaths annually across Europe. When it comes to housing policy, the health effects of air quality have to be balanced with the seemingly conflicting priorities of affordability, housing access, and environmental sustainability. Three critical elements which can appear mutually exclusive. The CO Research Trust has identified this as the housing trilemma. How do we balance safety and health with affordability and access while still focusing on environmental sustainability? COVID-19 brought the issue of air quality into sharper focus. In the first lockdown in the UK, we saw visible improvements in outdoor air quality around the world, yet indoor air quality remained largely ignored. The greater risk to human health and well-being is still perceived to be outside of the home environment, certainly in the UK. It's well established that there are higher incidences of CO exposure and other indoor pollutants during the winter months when people spend more time indoors. The pandemic has meant that people were forced to stay indoors more, even as the weather warmed up. According to the UK's Office for National Statistics, 1 in 8 households in Great Britain has no access to private or shared garden. This rises to more than 1 in 5 households in London. During the first lockdown, the government mandated that people would stay at home except for 1 hour of exercise a day. This would have increased the likely exposure to indoor pollutants for hundreds of thousands of people in the UK alone. A study by Professor Peter Green of Queen Mary University London concluded that deaths from COVID-19 were 70% higher in areas with increased levels of air pollution compared to the national average during the first wave of the pandemic. The report attributed high levels of particulate matter, nitrogen oxide and sulfur dioxide to the increased likelihood of dying from COVID-19. The number of deaths in areas with cleaner air were 40% below the UK national average. A clear link has been established between outside air pollution and the effects of COVID-19. However, no link has been made between the impact of indoor air quality and the effects of COVID-19. It's reasonable to assume that poor indoor air quality would have the same or greater effects and outcomes for COVID-19 sufferers. So we've been saying to the government that the issue of indoor air quality is more critical than ever. And we have a new building safety bill which is being presented by the government, and we've been lobbying the government to make indoor air quality a primary consideration. In the UK, as the restrictions are lifted and people mix, very many vulnerable people continue to shield themselves and stay indoors, fearing virus exposure. Older properties with older heating systems are associated with lower temperatures, high humidity, erratic air circulation and ventilation, all of which contribute to poor air quality. The CO Research Trust has been supporting research and actively campaigning on this subject. We understand the critical challenge for those developing housing policy, as weighing cost against environmental factors is a delicate balancing act in which health and safety considerations of indoor air quality often get left behind. Yet the primary function of homes as a place where people live and now work means that policies must encompass health and safety and well-being. If COVID-19 has done anything, it's helped to refocus our priorities on our own physical and mental health. Today, much of the innovation and policy making in housing has focused on new buildings and expensive technologies that have a low environmental impact. There are two main issues with this approach. Firstly, as concerns about energy efficiency has grown, buildings have become tighter. Increased insulation, additional weather stripping, high-tech windows and better construction techniques are designed to seal a house to prevent heat escape. This has obvious benefits from an environmental perspective, as we use less fuel to heat or cool a home. The downside to this approach is that an airtight home can exacerbate indoor air quality problems. Whilst this might be environmentally sound, the result can be a home with poor air quality. According to the US's Environmental Protection Agency, certain indoor air pollutants can be as much as 5 times higher than outdoor levels. Poor ventilation contributes to poor indoor air quality. Low ventilation rates and higher carbon dioxide concentrations in indoor air have been associated with adverse and perceived air quality outcomes. The second major issue with this housing policy is that it does not account for older homes in which most people live. The UK has the oldest housing stock in Europe. This is largely due to the legacy of dwellings being built during the Industrial Revolution, which still form the backbone of our urban societies today. From a policy perspective, this is an important omission which ignores the state of housing stocks, as well as the evidence and data on appropriate retrofitting solutions. The CO Research Trust is committed to helping change this through better regulation and policy making by providing evidence and data and making the case for new technologies which aim to make people safer and healthier. Of course, there are no safe levels of air pollution, whether it's indoors or outdoors. Air pollutants are present in every home. However, there are large groups of people who are being put at greater risk due to the current housing policy approach. This has been exacerbated by the COVID-19 pandemic and the increased requirements for people to remain at home. However, this has allowed us to build a better picture of the people who are at increased risk of exposure to indoor air pollutants. These include people who are already spending most of their time at home because they're shielding, who are already extremely vulnerable. Those living in modern houses, energy efficient properties that don't allow adequate airflow and ventilation. Also, people living in properties who have no access to gardens or outdoor space, who have no choice but to spend time indoors. Those living in older properties with old, inefficient and poorly maintained heating appliances. And then those living in areas with increased levels of outdoor air pollution, such as cities and major conurbations. Now we face the challenge of climate change and the pressure on nations to cut down emissions. Our lifestyles will change with less travelling and more home working. As we face up to the dual challenge of the housing trilemma and climate change, there's a unique opportunity to put health at the heart of housing policy and to protect vulnerable people who are currently being put at risk. So I just really wanted to give you a flavour of where the main thrust of our discussions with government and policymakers is at the moment. Certainly in developments over the last 5 to 10 years, the safety and health elements of housing policy have been put on the back burner, and we're working towards generating the evidence and the data that hopefully will help to put indoor air quality at the heart of policy making. So next, I just quickly wanted to show a quick slide about the COMA acronym. I'm not sure if this is used at all in the US, but it's increasingly used by health professionals in the UK. So there are 4 key questions which can be asked to help diagnose domestic carbon monoxide poisoning. These questions can be remembered using the acronym COMA. C is for cohabitees and co-occupants. Is there anyone in the house affected, including pets? O is for outdoors. Do your symptoms improve when you're out the house? M is for maintenance. Are heating and cooking appliances properly maintained? And finally, A is for alarm. Do you have a carbon monoxide alarm? The answers given for each question should raise or lower suspicion of poisoning by carbon monoxide. This has been promoted to healthcare professionals and other first responders. So finally, I thought I'd just run through some of the things that we've been up to over the last 18 months, 2 years. Briefly, we've been continuing to fund research. I don't propose going through all the research that we undertake at the moment. We have a page for each of our projects, past and present, on our website, www.coresearchtrust.org. But to give you a flavour, we are looking at developing a new biomarker. We currently have projects looking at developing new and novel blood biomarkers, a project looking at the use of pupillometry as a biomarker for CO exposure. We're undertaking surveys. We've worked with the emergency departments and fire and rescue services. We've worked with paramedics. We are currently looking at a project that will look at CO on lived on boats. We continue to look at comorbidities, focusing mostly on neurological conditions and the effect upon cardiovascular diseases. And then finally, we are continuing to look, as we have done for the last few years, at the effect of CO on susceptible and vulnerable groups. That includes older people, pregnant women and the unborn child, low-income homes, and other marginalised communities. Okay. So the next thing that we've done, and I'm hoping that you can just see my slides and you can't see my notes. We've commenced a workshop series, which is a monthly hour-long lecture and discussion covering some of the topics that we've been funding over the last 10 years. Our program is set now from sorry, I'm here on my own with my children at the moment, and I think one of them's just come in. No, she's gone. Okay. So I'll talk about the lecture series, but first of all, I'll cover the workshop series, which is the slide we're on. So we have, for a number of years, run a number of workshops. We've covered biomarkers, the medical management of CO. We've looked at cardiovascular disease, and we looked at CO and older people. The aim of these workshops has been to develop new ideas, which then can be developed into research projects that can be funded. Over the next 3 or 4 months, we've got a couple of these coming up. The first is the Fire Service Data Collection, Education and Awareness Workshop, which will take place on the 1st of December. This is a collaborative event which is being held by the CO Research Trust, the National Fire Chiefs Council in the UK, the International CO Research Network, and our friends at the National CO Awareness Association. I think Sharon's here on the call today. It's going to be an interactive workshop looking at the initiatives carried out by fire departments in the US and the UK that promote and improve carbon monoxide safety. Having just seen the previous presentation, it'd be great to have a chat with Kelly about this and see how the NFPA could be involved. As we all know, fire service professionals have a critical role in preventing CO incidents and raising awareness as trusted messengers who are already at work in this arena as part of their community home safety roles. At the event, the attendees will hear about current research and education initiatives, as well as from senior leaders in the fire service community about the challenges and opportunities in their states. The aim of the event is to establish a collaborative community of fire service professionals across the US and the UK who can work together to share knowledge, ideas and best practice and ultimately improve carbon monoxide safety for everyone. The second event, for which we haven't set a date yet, is looking at CO and the International Classification of Disease Codes. Causes of deaths are recorded using the ICD codes, a classification system developed and maintained by the World Health Organization and are used in around 117 countries worldwide. The system is currently in its 10th revision, although records considering the underlying causes of death from CO poisoning have been recorded in the UK using the previous revision, ICD-9. In the UK, the Office for National Statistics codes all causes of death mentioned on the death certificate using ICD codes. From the list of causes mentioned on the death certificate using the automatic ICD coding rules, the underlying cause of death is obtained. The underlying cause of death is defined by the World Health Organization as the disease or injury that initiated the train of events directly leading to death, or the circumstances or accident or violence that produced the fatal injury or poisoning. CO itself is not recorded as a cause of death, but will be identified if coded as an underlying cause of death. For this coding to be completed, specific terms from the death certificate are coded, and using the computer algorithms, the assignment of the underlying cause of death is suggested. Deaths attributed to poisoning such as CO are considered according to the underlying cause of death, and secondly, by the nature of the injury. Only one underlying cause of death can be given. The calculation of the UK's mortality rate for non-fire-related, non-suicide exposure to CO is based on the average number of accidental poisonings by other gas vapours, which is code X47, and where the secondary cause of death was the toxic effect of carbon monoxide, which is the code T58. In the UK, statistics on death collated from 2004 to 2017 show a gradual decline from around 40 deaths to the current figure of about 25 deaths a year from accidental CO poisoning. These ICD codes have been much discussed at meetings in the UK, and we've been asked to organise a formal meeting to look at these codes. Finally, for what is the UK's financial year, we're looking at the detection, monitoring, prevention and the role of technology of innovation in reducing low CO exposure. The CO Research Trust and COGDEM, which is the Council for Gas Detection and Environmental Monitoring, we're organising an event to try and better join up the CO-related research that's going on with the manufacturers of emerging smart detection and monitoring devices. As I said before, the CO Research Trust funds a number of research projects looking at low-level exposure on at-risk groups. This includes the elderly, pregnant women, unborn child, neurological conditions, as well as cardiovascular disease. The aim of this workshop is to highlight this work to innovators who may be able to incorporate it into the development of new technologies and smart systems. The idea is that we get the innovators working in this area in a room where they can hear about the work that's been undertaken and look at how collaborative partnerships might be formed and how it might be incorporated into the new technologies. This is the first half of the programme. The second half will be around short presentations on the new technologies that are out there on the market. We haven't got a date for that one either, but I hope to be able to confirm the date for that in the coming weeks. I started to talk about the lecture series. Got a bit confused with the child bursting in, but we have set up a series of lectures that run from September to March, and it's something we're going to do annually. We have a full programme for this year, but the aim is to roll this on year after year. In September, we heard from Dr. Andrew Spowage from Queen Mary's University, London. He's produced a white paper that looks at CO and light aircraft. Both the lecture and the white paper are on our website. A fortnight ago, we had Beth Cheshire, who is at Lancaster University. She's a PhD candidate. She's coming to the end of her PhD. Those of you who attended the ICORN event that took place in Minnesota, about 3 years ago now, would have met her at the beginning of her research. So she's just about to do a Viva, and she's coming to the end of that in December. Again, her PhD will be published on the website once it's completed, but there is the lecture on the website if you wanted to have a look at that. This month, we've got Dr. James Hanlon coming from the Institute of Occupational Medicine. He undertook a review of the solid fuel industry on our behalf. In the UK, the gas industry is fairly well regulated in terms of who can install appliances, who can maintain them, and the process for recording incidents. In terms of the solid fuel industry, it's much less regulated. Anybody can buy a wood-burning stove and install it in their home, and there's no way of checking that it's being maintained or that it was installed correctly. So that will take place on the 25th of November. Looking forward, next month, we've got Professor Heather Jarman from St George's Tooting. They've undertaken a piece of work looking at emergency departments. This is a project that she's the principal investigator on. They've been collecting data and picking up patients across 4 emergency departments in the south of England, picking them up based on people presenting themselves with a number of symptoms, and then with their permission testing them for CO, and where CO has been identified, then going into the home and testing the appliances. So this will be an opportunity to hear some of the findings from that project. Then in January, we've got Dr. Ewan Sandiland from the National Poisons Information Service. They are pretty much like your poison centers in the US. They act as a information service for healthcare professionals in the UK. They run the TOX-based system. They've been collecting data for the last 5 years, understanding the awareness amongst healthcare professionals and medics. They've got an interesting data set which has incident data, but also how different parts of the healthcare community, understand CO exposure. Then in February, we've got Isabella Myers. She will be presenting a report looking at the coronial system in the UK. It includes, I guess, a lot of information about the ICD codes that I mentioned briefly. We've had an introduction of an additional sort of tier of administration in the UK. So she is going to talk about that and how there is an opportunity to close the loop on CO data. I'm quite mindful of the time now, so I'm going to try and speed up. I don't want to derail the summit. Looking forward to the future. Next year in the spring, for the first time, we'll be holding a 2-day conference It'll be an opportunity to present the research that we've been carrying out over the last few years, to announce the new projects that we're going to be funding. We're currently going through a grants process, and also to hold a sandpit event where we're going to bring together experts from a number of different disciplines, and we hope that that will provoke some new ideas and perhaps some larger long-term projects. We want to improve our international collaboration. It's always a treat to come and speak to you guys. We work with the guys in Minneapolis. I'm hoping that we can work more formally with the NCOAA in the next year. I know that they have some very, very exciting plans, and I hope that we can contribute and be a part of that. We're revising our grants process. We're hoping to make it more robust, make it more transparent, and hopefully encourage people from outside of the CO community to apply and work in this area. And then finally, the plan is to continue our events program for 2022-23, continue the lecture series next year. I would say that we'll be looking at our own research, but it's always interesting to hear initiatives that are going on elsewhere. So if anyone has a burning desire to speak to us here in the UK, then please do get in touch with me. We'll be continuing our workshop series. It's a big part of what we do to provoke, new thinking and collaboration, and hopefully to generate some new ideas. And then sponsorship. We like to work in partnership. We always have a budget to support people's initiatives. We're in a relatively privileged position, I guess, as it goes, to have some cash in the bank that we can spend on research and other activities. I know that there are other organisations that are doing good things that aren't as fortunate, and we always like to try and help out and support if we can. So I can breathe now. Thank you for having me and listening to me for the last half an hour. My email address is there. Please do get in touch if you have any queries on the presentation.